Good afternoon, everybody. My name is Juan Director of the Hanford Transplant Institute, and I would like to welcome you to the Transplant Institute lecture series. Please, if you don't mind, remember to mute your microphones as we conduct this grand rounds, and please type your questions into the chat box, and we'll pick those up at the end of the presentation. It's my privilege today to introduce Dr. Juan Caicedo, from Northwestern, who will speak to us today about increasing living organ donation and transplantation in minorities through a culturally targeted transplant program. Dr. Caicedo is a native of Colombia, where he did his MD and residency at the School of Medicine in Universidad Nacional de Colombia in Bogota, Colombia. And subsequently, he did a clinical transplant fellowship that is ASTS accredited at Northwestern Memorial Hospital in Chicago, Illinois. He also completed a fellowship in pediatric transplantation. We also did some research. He had stayed on faculty where he has grown in his various positions to become the surgical director of the liver transplant program, the director of living donor liver transplantation and hepatobiliary surgery, and also the founding director of the Hispanic transplant program at Northwestern Memorial Hospital, the Feinberg School of Medicine. Dr. Caicedo is a very busy man. He has involved in many activities within and outside his organization. He's the founding member of the Colombian Transplant Society and the inaugural chair of the Diversity Issues Committee of the American Society of Transplant Surgeons. He was a member of the White House Blue Ribbon Advisory Group, board group to establish a national clearinghouse for educational resources about transplantation and living donation. He also serves on the OPTN UNOS Minority Affairs Committee as leader of the Cultural Competency Work Group. In his institution, he has done some work also in that space with extensive involvement with the medical school, where he is the co-leader of the Informed Consent for Minorities group at Northwestern. He's on the Dean's Faculty Diversity Task Force and serves as a member of the Quality of Life Work Group as well. He is NIH funded with the culturally targeted program in transplantation to increase donation in Hispanics. And we're very excited for Dr. Caicedo. Personally, he is a wonderful human being with whom I worked with through the ASTS and outside. And please join me in welcoming Dr. Caicedo. Dr. Caicedo, welcome on board. The floor is yours.
Thank you very much, Dr. Aboud. Thank you so much for inviting me. This is truly an honor, a pleasure to be with all of you. I really appreciate for the opportunity. And of course, I would love to be with you in person, but this is still a good venue to talk and to exchange ideas. Then basically, I'll be talking about what I have been working on for the whole career here in US. And I have been focusing on how to increase living organ donation and transplantation minorities through a culturally targeted transplant program. Then, let me see if I can move it. Yes. Then my only disclosure, some of the information that I'm presenting is part of the information that was helpful when we were applying for the NIH NIDDK R01. And then where I'm the co-PI with Dr. Lisa Gordon. Basically, in this grant, we have been focusing, or the title of the grant was a culturally targeted transplant program to increase live donation in Hispanics. But still, I think the objectives of my presentation is not only talk about a little bit about Hispanics, but how this information can be applied maybe to other groups. Then I'm going to focus more on Hispanics, of course. We're going to review some relevant Hispanic American facts. Then we're going to describe some disparities in Hispanic Americans' access to transplantation and living donation. I will try to articulate some cultural and linguistic issues and Hispanic patient preferences. And this is essential for me because we, as a providers, most of the time we're thinking what the regulatory organizations or institutions are telling us to tell the patients, why we as a provider want to tell the patient, but sometimes we forget, more importantly, we have to answer or respond to what the patient needs from us. And we need to consider the patient's preference and consider all of these things, how that knowledge can help us to inform strategies for improving living kidney and liver donation in Hispanics. I'm going to describe how the Hispanic Transplant Program at Northwestern Medicine here in Chicago has been associated with increasing living kidney and liver donation in Hispanics. And at the end, I'm going to mention very quickly, based on this experience, targeting the Hispanic Americans, now we're developing a new program focusing in African Americans. And the program is called African American Access Transplant Program. Then every group has different cultural issues that we have to acknowledge in order to create new strategies for those people. Then let me very quickly start reviewing some relevant Hispanic facts. First of all, from the US population, according with the US Census Bureau, whites or non-Hispanic whites are 60% of the population, but that means that minorities, the rest, are 40%. This is essential. Then again, although I'm not going to be talking about politics, I think this is the best nation on earth based on the diversity that we have. And we have to embrace that, and we have to recognize that. And this is something that many times we're missing, that we don't recognize who we are as a population, the minority percent of the population. Now, focusing on Hispanic Americans, from the more than 328 million people in US, Hispanic Americans are more than 60 million. That is 8.5%. Now is the largest minority, as everybody knows. And what is important to recognize, Hispanics accounted for more than half of the nation's growth between 2010 and 2019. Prior to this time period, the previous decade, Hispanics were growing 43% when the rest of the population was growing 5%. And that is also important fact to keep in mind. And another important fact about this community is we have a young community. The mean age for this population is 30 years old. It's the youngest community. And that has some implication when we're talking about transplantation too, and about outcomes. And here is a graph just to show how much the Hispanic has grown over time. In 1970, it was 9.6 million. Now we're talking about more than 60 million in the nation. And here, just a few pictures about the geographic distribution of Hispanics in the country. Then just, this is 1980. And then in this graph, or in this map, you can see how is the growth in 1990s. This is in 2000, 2006. And this is 2011. Then you see how Hispanics are spreading throughout the whole nation. And of course, there's a higher concentration of Hispanics in the South and in Southwest, but still there's Hispanics all over the place. Another important fact that we need to consider is what is the distribution of Hispanic Americans in US, from where they're coming from. Then 62% of those people are coming from Mexico. And when we're talking about living donation, I think it's also relevant. I think there's difference between Mexicans, Puerto Ricans, Cubans, South Americans, or Central American regarding living donation. Those facts are important to consider. Now, another important cultural fact is that for many, when people say this community has big families, a social problem, but when we're talking about transplantation, to have big families is a big advantage. And here in this graph, as you can see, Hispanics compared to the rest of the population, they have big families. What is a beautiful thing when we're talking about organ donation and transplantation. But most of the centers across the nation don't recognize this fact and don't invite the families many times. And if you involve family, you can do something and you can change what is happening in this community regarding organ donation and transplantation, as I'm going to show you in a moment. Now, why to talk about Hispanics? You know, a lot of people say, you know, they are poor, they have lower income, everything that could be true, but they are growing the most. Then, just to mention one thing, Hispanic consumers spend 1.3 trillion. And in case my Colombian accent doesn't convey, is with T, trillions. It's a lot of money too. And that was in 2015. And you can see here the growth of the Hispanic buying capacity or buying power. And by 2020, the buying capacity was 1.5 trillion. And it's important to remember that the total buying power of this community has increased in 212% this decade. And that's why the Hispanic market is one of the main drivers of the overall market. Then the baby boomers now are retiring, and they are not moving the economy as much as the communities that are growing the most. And one of the communities that are growing the most are the Hispanics, as I just mentioned. Now, let me focus on transplantation. Then let's talk a little bit about the kidney waiting list and transplantation in Hispanics and in minorities in general. Then everybody knows this graph. Then basically there's a big discrepancy between the supplied organ versus the big need that we have. And by 2020, we have almost 100,000 patients on the waiting list. And then we're doing only 22,000 or something like that. And the number of transplants that we're performing are not growing in the same proportion of the need. And unfortunately, more than 4,600 people are dying or dying in 2020 when they were in the waiting list. And then this graph, even though we can see this is just the last annual report from the OPTN SRTR, then we can see even how the number of patients on the waiting list maybe is slightly decreasing, but it still is too high. The demand is too high compared with the supply of organs. Now, when we are analyzing the kidney transplant waiting list by race and ethnicity, then before we said minorities as a population is 40% of the total. But now when we are talking about in the kidney waiting list, whites are, this is non-Hispanic whites to be correct or exact, are only 36%. That means that minorities, the rest, in some fashion are 64%. Then here is one of the issues. Most of the centers, they developed their initiatives as they were targeting the minorities, or everyone focusing just on whites. But when you analyze the patients that we're serving, whites are actually right now minorities. The minorities are the majorities in the waiting list, and that is a problem. Because most centers should be focusing on creating new programs or new initiatives to focus or target minorities. And when we analyze all the websites of every kidney transplant program in the nation, was very interesting to see for example, the number of websites translated in different language besides English was like 8 or 9%, right? And the number of culturally sensitive initiatives. And we're not looking for high quality initiative. We're looking for any bad translated letter that is in the website. Only like 3 or 4% of the programs has initiatives targeting minorities. Then here clearly the transplant programs don't understand the market that they are serving, at least based on the analysis of the community that we are serving in general. Then here's where there's a huge opportunity to improve access to transplant care and improve, transplant care in general for minority communities. Then minorities receive fewer kidneys from live donors than whites. Then here I'm just giving the last 2 years, 2019 and 2020. 2020 is a weird year for the COVID. Then let's forget about 2020. But let's say 2019 was a normal year. Then in general, from all whites receiving a kidney transplant, 42% receiving a living donor, and Hispanic was only 24%. Then remember that number, 25% of Hispanic receiving a kidney were receiving a living donor. And Asians were receiving a little bit more than Hispanics, and African American has even lower living donation rate. Now, some facts about Hispanic Americans and kidney transplantation. First of all, they have the highest growth in the kidney transplant waiting list. And that is kind of understandable based on the growth in general as a population, right? And they have one of the longest waiting list time. And they have the highest waiting list mortality when we compare with non-Hispanic whites and African Americans. And the Hispanic Americans are disproportionately affected by organ shortage, as they have high prevalence of end-stage renal disease and yet exhibit low rates of living kidney donation, as well living liver donation compared with non-Hispanic whites in general. But as soon as we transplant them, and there's the Hispanic paradox that actually we publish in transplantation, where we show how Hispanics, as soon as they get transplanted, they have the same or better outcome compared with non-Hispanic whites. And again, we have to remember this is a young community. Maybe this is something that helps, but also there's no biological factors like they are very family oriented. They have big families. Even if the patient is too sick, if we involve the family, they will be very supportive and they will help the patient. Now, there's multiple barriers for patient and potential living donors. Then, starting with language, including difference in dialect, is not the same. For China, there's 1,000 different dialects. For Latin America, even though most of us speak Spanish, but there's some difference between countries that we need to understand. There's cultural difference between patients and providers. And unfortunately, that creates distrust in two ways. It's not only the distrust of patients to the system, as the African American has, and we have been lately talking about a lot about it, but also there's a distrust of provider. There's a lot of biases or blind spots from the providers. Sometimes they feel, should we help Hispanics? Why? Makes sense? Why we should do it? They don't have insurance. They cannot get insurance because maybe they are no citizens or they haven't documented. All of these wrong ideas, and then hopefully I will try to remove those ideas through talk. Then again, there's distrust of the providers too, because they don't understand the patient's culture. And there's a lack of community awareness, and there's a lot of misconceptions about organ donation and transplantation in this community. And these barriers impair the access to preventive care, health education, and some treatment options. Then we need to deal with those. Then here, I just want to focus. We did a couple of studies that we published, and the reference are below. Then where we did a survey to all transplant centers, then we are interested to learn how they were providing the transplant education. It was very interesting to see in the right column how most of the centers, the formats of the education was in English, right? And they were focusing more on written material, and they were doing the education one-on-one. And the education was given by non-physicians, nurses, social workers, PAs, and others, and they rely upon interpreters a lot. But I think what is essential, what most of the centers are missing, is to understand what are the Hispanic preferences. And when you ask the Hispanics, and actually, by the way, even though there's a second and third generation and the need to, how much they speak English or Spanish change over time, but when you ask in general, the Hispanic community at home, 75% of this community speak Spanish at home. And when you asking them how they would prefer to receive the education, they will say, I would prefer to receive it in Spanish. And they prefer face-to-face interaction. We are kind of social. We are very warm. We use your hands, we hug, we shake hands, and it's part of our culture. If we don't do that, the interaction is not as good. And they prefer group discussion instead of one-on-one. And I think one of the issues to the one-on-one education, when we are evaluating patients for transplantation, that is probably the best way to scare people. When we are thinking of the CMS, the LPTN, and everything, what we need to tell them, you can die, you can have all these complications and everything. This is the best way to scare them away. But themselves, they don't speak the language. I came to this country, and I'm very, very grateful to be here, but when I arrived, I didn't speak any English. And well, very little. And then I struggle a lot. Then I understand what our people is suffering. And when we are talking about this type of information that is critical, they will prefer to have a group discussion, the patient with the whole family. Well, I use an analogy. Let's see if it works today. I compare Hispanics. We are like a deers. If I'm in the middle of the jungle, I'm by myself, and I sense that in the bushes there is a tiger or something moving. I'm the single deer. You think I'm going to stay there just to see if the tiger is going to eat me? What I'm going to do? I'm going to run away. But if there's 20 deers and they sense something moving, they start looking at each other and they're going to stay a little longer. Maybe one of them is going to die, but they will stay longer because the group create that kind of calmness at least, or at least they feel a little more comfortable. Then in general, patients or Hispanic patients prefer group discussion, no one-on-one. And they prefer the education given by physicians. Then let me say something. MD in Spanish means medio Dios. Translated to English is half God. For Hispanic culture, in the Hispanic culture, they really respect the priests as well physicians. And we have an authoritative figure that we have to use. But many times in US, all the physicians, we feel like we're so busy, as Dr. Abel-Jude was saying, and we are very busy, but it's still, I think we need to contribute with education. Education is no one-time event. Everybody needs to contribute. And even though the nurses, PAs, and social workers, probably they know better the education than us physicians, but we have that authoritative figure that will help. The patients feel they trust more, they feel more comfortable when the physician is talking to them, especially the one they're going to do the transplant, or the nephrologist, for example. Then that is essential. And that is something that most of the time people don't do. And they don't like, they prefer bilingual, bicultural educators. They're bilingual, they speak the two languages, and they understand both cultures. They will prefer to have a congruent team. And they don't, I mean, interpreters, if they are certified, there's fantastic interpreters, but sometimes they can become barriers in the communication. Then I think that is essential. Then when we are considering the decision-making process about leaving kidney donation as well leaving liver donation, there's three key elements in the Hispanic community. First of all, the decision makers. The decision makers in this community are the elders. It's grandma, la abuelita. If you're dying or you're getting married, you're going to ask grandma, you know, if this is the right decision or not. You're going to request their blessing, her blessing, or grandpa. Then that's why you have to involve the elders when patients are coming to your clinic. And then even though I don't want to be the donors, sometimes grandma has been donors, but what I really interested in their blessing. Blessing, because now I'm going to address the second group, is the family or the support network. And usually, as there is a big family, there's a lot of young people. Of course, we have a lot of diabetes, hypertension, obesity, but still, if there's big family, there's more opportunity to find somebody that could donate. And then what you have to address to them is really, you have to address the fears that they may have. Then I would love if we could be, you know, in person to have the feedback from you. But clearly, when you're talking about a young Hispanic females, usually what they are worried about is not if they can die of complication about the procedure. What they are really concerned about if they can have babies, if they can become pregnant. And if you're talking a young Hispanic males, again, they are not worried if they can die or if they can have develop complications. Sometimes what really is in their minds, they have the notion or the misperception or the myth that if they donate a kidney, they are going to have sexual performance issues. And as soon as you say, no, you can work, you can exercise, you can have sex, you can, then they open their eyes and say, oh, grandma is giving the blessing and I can be okay, maybe I should consider it. And then you have to deal with the third element of this decision-making process, the patient. Sometimes the patient is the biggest problem because they don't want to take an organ from a loved one. then that's why it's a mistake in my view when people just educate or evaluate the patient by themselves with no other members of the family. And if you ask them, do you have living donors? They will say no, 70 to 80% of the time, even if they have to. Then that's why when I'm at the end of my clinics, I use like a wrap-up session is where I just answer the final questions and I ask them if they have potential donors in front of the whole family, looking to the recipient. And it's interesting to see how the recipient said, no, I don't have, and the daughter, the son, the wife, or whoever is there say, of course, ma'am, or dad, or grandma, I want to be. And it's just beautiful. You just relax and you allow the family to talk, and it's an act of love. And as John Paul II said, this is a very charismatic Pope, Catholic Pope. He used to say something like, the biggest act of love was to donate an organ. Or Pope Francis also is in favor of organ donation, and most of the religions are in favor of organ donation. And then it's important when we talk, when I'm addressing all elders, I talk about religion a lot, and then they will give the blessing, and one of the young people will consider, and then I have to address the concerns of the patients to use a loved one. And again, usually it's due to lack of information. Then that is essential. And this very basic concept, but it's just based on understanding the culture. That was the base of our program that we developed. And later on into our application, when we're developing the intervention that we want to test in our NIH grant. Then we developed the Hispanic Transplant Program as a response of the Hispanic health disparity in transplantation and to meet the need of this growing population in our area, initially in Chicago. I came here as a fellow. I didn't speak too much English, but sometimes I was translated to the patient, and I understood there was a big need. And our former boss that I love dearly, Abekasis, he understood. He said, well, there's a need, then nobody has this, why we don't develop something? And then we develop a comprehensive culturally and linguistically competent, meaning that we understand the culture, but also we share that culture, and the same with the language. Not only we understand the language, but also is my first language. And we developed the program. This was the first Hispanic transplant program in the country. I was surprised because I was assuming that everybody has Hispanic transplant program, but when I start searching every program across the country, nobody has an initiative developed to target this community. Then we started the Hispanic kidney transplant program in 2006. We started the Hispanic liver transplant in 2010. Now we have, I think it's 49 bilingual, bicultural staff team members, including surgeons, hepatologists, nephrologists, social workers, transplant nurses, fellows. 3 of my fellows right now are Hispanics, and the next one coming, one of them is Hispanic, just to say something. Then I started the program by myself with the support of Dr. Abekasis and the hospital, but it has been a process. Through the years, we're trying to reallocate people, and we identify people that speak the language, speak Spanish, or they're Hispanics, and then we're moving them to our program. And now we're providing all the experience in Spanish. Now, then we have a bilingual, bicultural staff. Again, everything is in Spanish, and we're targeting Hispanic patients, family, and decision makers. Then when we are doing the clinics, I'm like a lazy priest. I don't want to repeat myself 10 times. When you're doing one-on-one discussion, then you have to repeat yourself 10 times. And when people are using translator, it's going to take 1.5 times if you're doing the education in English to regular non-Hispanic whites. Then basically we start with education at front before we evaluate the patients, and then in that way the lazy priest, Catholic priest is like this, everyone at the same time. Then I spend my 1.5 hours at front. Then whenever I start seeing patients individually, I already have addressed all the cultural issues, and then the clinic move faster, they understand the process better, and now they're opening to even consider living donation and everything. Then In this clinic, we are targeting the patient, the family, decision makers, and we do face-to-face education. We do more group interactions instead of one-on-one, as based on the patient's preference or his preference, and the education is given by the surgeons that are Hispanics. We are two Hispanic surgeons now. And we're focusing on cultural, language, health-related financial concerns, preventing Hispanic families from considering living kidney donation, as well kidney transplantation, and the same for living liver donation and liver transplantation. And we have decreased the use of translators. Now, then to deal with these specific obstacles for living kidney donation Hispanics, we have to, beside what I mentioned before, we have to address the language barrier, we have to address issues related culture and education, influential role of the extended family, religion, lack of knowledge, fear of donation and surgery, cultural desire to avoid harming potential donors, resulting in not asking for donation or not accepting the donation many times, and this is very frequent, and healthcare professional attitude. That has been also an issue. There's a lot of biases from the teams that we have to deal with, and there's financial legal concerns that we have to address too. Very quickly, I'm going to show outcomes, our kidney transplant program, as well our Hispanic liver transplant program. Then, first of all, to say, with all this education that is given in Spanish, understanding the culture, the language, has allowed us to improve. When we are measuring knowledge and attitude towards living kidney donation, has improved the knowledge and attitude not only of the patient, but also the family and friends in a significant way, as you can see in this table. But also, when we are analyzing what happened to our patients, when we compare before and after implementation of our program. And then just to give you an idea, here in Northwestern, we have done around almost 5,500 kidney transplant. We're doing around 200 to 250, depends on the year. And then initially, Hispanics was a very small group of percentage of our population coming to Northwestern. And then we started the program in 2006. And then when we compare before and after implementation of the program, we can see how the addition to the waiting list, and this can be a measure of how we're improving the access to transplant care, we are able to increase the additions to the waiting list in 91% in Hispanics. When in non-Hispanics, why in these two periods of time was like a 4% growth. The number of living donor kidney transplants increased in Hispanics in 74%. And more importantly, when we compare Hispanics versus non-Hispanics living donor kidney transplant, that ratio can tell us it's a metric of disparity. We're able to decrease that ratio in 70%, meaning that disparity was improved in 70% in a significant way. Now, in 2000, again, when we started the program, Hispanics were very small in Northwestern. And then they start growing, and that allows to grow our numbers. And in 2012 and 2013, actually, we're number one in the nation doing living donor kidney transplant. We are not now. But at that point, the growth in Hispanics was the one that allowed us to be number one in the nation doing living donors. And interestingly, at that time, in the nation, for example, Hispanics receiving a living donor was only 31%. In Northwestern was 65%. We have had years from 65 to up to 78%. And this proportion were higher in Hispanics than Asians or whites and African Americans. Then this is opposed to what most of the center were seeing across the country. When we started the program, before 2006, Chicago is a very competitive market. There was other centers doing more transplant in Hispanics than us. We started in December 2006, our program, and very quickly we were able to increase our number of Hispanics in Northwestern and purple here. And then basically we started dominating the market that before we were not dominating. And then that was interesting for the hospital. Initially, the hospital were saying, hey, it's a good idea to attract all the Hispanics. What about if they don't have insurance and what is going to happen? And that was very interesting. Then we developed a strategy. And now I can tell you over time, now Hispanics, and most of them, they are no residents or citizens, they will have private insurance. And Hispanics now has better the payer mix compared with whites. And that was something that was not expected by, for example, the administration, the hospital. And now they're pretty happy about it. Then this table, I don't pretend that you're going to read it, but it's just to mention one thing. Initially, I was interested to know if the outcomes that we're having in Northwestern were similar to the rest of the centers here in the city. Then I started analyzing the other centers in the city, other centers across the country located in areas with high concentration of Hispanics. Then that's why you have here, you have Connecticut, Rhode Island, New Jersey, Florida, Texas, Arizona, California, all the Illinois, Colorado, New York. Then basically we're the only ones seeing this type of growth and decreasing in disparity across the country. And then we start thinking, if we can disseminate this type of initiatives, even if we have a very low adoption rate, 10% adoption rate of these type of initiatives, and if every center increased just by 5 or 10 living donor kidney transplants, right? At the national level, we can start seeing significant growth, 11, 22%. And if the adoption rate goes to 30%, still with this small increase, still we can have an impact at the national level in the number of living donor kidney transplant in 30, 60% or so. Then this was kind of our motivation, say, well, maybe there's something here and we need to try and see if this works. Then that's why we apply for NIH, multiple attempts, always they refuse, they say no, there's nobody that can implement this type of initiative, they told me once, and that's why I start analyzing all the kidney transplant programs in the nation, and I learned that in transplantation, we have a very diverse workforce, and we are not capitalizing on that. And there's Hispanics, and why? And when we analyze all, for example, the top 100 kidney transplant program in the nation that transplant probably around 75 to 80% of all kidneys in the nation, when you analyze those centers, probably 80% of those centers at least have one bilingual provider, a nephrologist or transplant surgeon. Then my point is why we have a diverse workforce, why we are now having more culturally sensitive initiatives in every program. And for me, has allowed me to grow professionally doing this. And again, the same will be for people. Then they will have their own little thing, right? The Hispanic program was a small thing when we start from nothing, and I was the only one. Now we have 49 people. And from the percentage of Hispanics receiving a kidney transplant in Northwestern was only 9% before the program. Now it's 25%. Now for the institution, it's an important component of what we do. Then now, very briefly, just to make sure that we have time for questions, then the Hispanic liver transplant program. Then we start in 2010, when we start analyzing before and after implementation of the program, we can see, and here in Northwestern, we have done around 2,200 liver transplant. We do around 100, 120 adult liver transplant. This is without counting children or pediatric transplant. And in some point, we were doing a decent number of living donors. Even, we were number one at some point. Now we are not. And then we're working to improve things. But anyhow, just to mention, we are able to increase for Hispanics the additions to the waiting list for liver transplantation in 54%, when in the nation was only 25% in this period of time, and the non-Hispanic whites actually were decreasing in my institution. The number of liver transplant increased 54. We're educating them. They are getting ready to accept hepatitis C donors and donors after cardiac death and all this. If we educate our patients better, they will consider other options. And that's why our transplant rate in Northwestern for liver transplantation, I think it has been around 150, 140, 150, when the nation is around 60. Then basically we try to capitalize all the options for patients. The number, that was interesting, even though the number of living donor liver transplant is smaller compared with kidneys. For living donor liver transplantation in Hispanics, when we compare before and after, we saw an increase in 88%. Then, as a whole, the Hispanic transplant program in 2021, we have transplanted more than 1,200 patients in Northwestern, around 900 kidney transplants. 50% of those receiving a living donor, when in the US is 24%, as we were saying before. Then they have overall higher living donation rate, or are getting more living donors. And as I mentioned before the Hispanic program at Northwestern, Hispanics were only 9%. Now it's around 25%. They have grown. Now, regarding livers, we have done more than 260 liver transplant in Hispanics. 10% of those has been living donors. In the nation is living donor liver transplantation around 4 to 6%. Then still they're having higher proportion. And we have done KPs, pancreas alone and pancreas after kidney in Hispanics. And this is our team now. Our bilingual, bicultural transplant team. And just briefly to mention, based on that experience in Hispanics, then Dr. Abecassis understood that there was still a huge need for other groups. And then we were able to recruit, African Americans are 13% of the population after Hispanics, but still they represent 35% of the patients with kidney disease in US. And actually, African Americans are, after whites, non-Hispanic whites, are the second group waiting for a kidney currently. Hispanic has fastest growth, but still African Americans are the second group. And they have 4 times more risk to develop kidney disease for different factors, as you know. They have more diabetes, hypertension, genetic predisposition. There's other additional factors that here is very important to consider that are not the social determinants of health. They include economic stability, neighborhood and living conditions, access to education, access of healthy food options, access to preventive health care, and especially health care. And they have lower access to kidney transplantation as well, including living donation. And it's less likely that they will complete the evaluation process. Then for that reason, and in Chicago is also very interesting. The population in Chicago is kind of 1/3. 1/3 is whites, 1/3 is African Americans, and 1/3 is Hispanics. Then that is another important fact about Chicago. And then I was saying how following the experience of this Hispanic transplant program, our division, led at that point by Dr. Abecassis, understood the need, and they decided to hire an African American transplant surgeon. When people sharing the same race or culture or language, that is important if it's possible. If it's not possible, that's fine. But we can have congruency with the patient that we're serving. That is very helpful. And then we start a program focusing on African Americans. And Dr. Dinae Simpson, Dr. Marwan, Dr. Awoju know very well, that has been working with him in the ASTS. She is the lead person. She's the only African American transplant surgeon in Illinois, actually. And she's developing these African American transplant access program to improve education and access for these at-risk community. Then just few words about immigrant residents and undocumented immigrants. There is part of the biases that some members of the team, they were saying, well, the undocumented, we shouldn't transplant them. They don't pay taxes. They can get insurance because they don't have social security numbers. And all of these things is not true. And then that's why I just want to say a few words about that. First of all, from everyone in this country has immigrated in some point. The Native Americans is less than 1%. All of us now or in previous generation our family had migrated here. That's the first thing that we have to recognize. Second, the issue about if the undocumented pay taxes or not actually is not true. They pay taxes. There's two certain things for us living in America. One, that we have to pay taxes, whoever we are, and second, that we're going to die one day. That's certain, right? The Uncle Sam or the IRS never is losing money. They're always getting our money on our taxes. And the undocumented immigrants are paying around $11 billion. And in Illinois is like a 750 millions. And there is the IRS create the individual taxpayer identification number, the IT. It's a tax processing number issued by the IRS to ensure that people, including undocumented immigrants, pay taxes even if they don't have Social Security number and regardless of their immigration status. And it's important for people to understand that the insurance companies, they care about the business, and they understand this is a growing population, and they pay for private insurance. And that's why they don't, most of them, they don't request or they don't need or require to have a Social Security number. And a lot of social workers sometimes don't know this fact. A lot of providers don't know that. And some people say, well, if they're undocumented or legal, they can be listed in units. That is also not true, because our team can request the 9FN number that substitutes the Social Security number, and patients can be listed. And also, it's important to notice that the number of immigrants that are no citizens is only 1% of the kidney transplant recipient in US. But when you are seeing the number of donors is 3.3% of the donor pool are non-citizens, meaning that probably they are donating more, 3 times more than they are getting. That is also, we have to consider. Here in Illinois, our OPO, Give a Hope, in our OPO, 4.5% of the total disease, I'm sorry for the type error there, deceased donors are non-citizen. It's even higher. And I was part of the Hispanic Council of Give a Hope, and now I'm a board member. And at that time in 2013, we were having problems in Chicago. There was a priest that was protesting, saying that the transplant programs were not transplanting Hispanics, and that was affecting the disease donation rate a lot. They were started thinking how we can fix this issue. Then we learned that there was a lot of patients that were undocumented, and they were getting the insurance paid by the American Kidney Foundation. This is something that has been working since 1974 or something like that. Actually, was the biggest dialysis companies, David and Fresenius. They were donating money to a non-for-profit organization, American Kidney Foundation, and they were paying the private insurance. Initially, when I heard this, I thought maybe this is kind of weird thing. Maybe it's not legal, but actually it has been completely legal since 1970s. And then we say, well, we don't set up something like that. Let's enjoy. I mean, there's a lot of rich people also in the Hispanic community. Why not the community can start donating money? Why don't the transplant programs work together, even though we have a competitive market, and the community in general? And then we're able to engage other transplant programs in Chicago. The hospitals donate money for what we create, the Illinois Transplant Fund, that was supported by Give a Hope. And that has been part of the solution. Then what is this Illinois Transplant Fund? They help to pay the premium insurance for patients that in the program that was paid by the American Kidney Foundation, that will cover only dialysis. But as soon as the patient is transplanted, that insurance won't work any longer. Then we have a solution to be able to transplant the patient, to be able to make sure that they have the insurance to pay for the medication, for the follow-ups. And then that was the idea. The Illinois Transplant Fund will help, after we engage all the community and the transplant hospitals to donate money, the fund will pay the premium of this patient then for 3 years, and in some cases, depends on the need, it will extend it. But what we have seen over time is people are grateful they're getting the opportunity, and as soon as they get transplanted, they start working and they start paying to allow other people to get into the system. And in that way, we have been able not only to do kidney transplant, but also liver, heart, and lung transplant for people that were uninsured, regardless the ethnicity or race. But most of them, some of them has been Hispanics. Then just to mention, here we have, for example, in Northwestern now 72 patients that has been approved by the Illinois Transplant Fund. We have transplanted more than 60 people. We still have 22 people listed, but we have been able to do liver transplant, kidney, pancreas, heart, lungs, and then it's a solution. Then for us, when the patient arrive with bad insurance, that's a big problem. But if they don't have insurance, there is options for them. We're the only one in the country with this type of plans. This is here in Illinois. And in conclusion, culturally targeted transplant programs can increase patients' and family knowledge about living kidney donation and increase favorably attitudes towards living kidney donation, perhaps contributing to the increase in number of potential donors initiating evaluation and the number of living donor kidney transplants. This type of culturally sensitive strategies can help to reduce living donor kidney transplant disparity in Hispanics, and these similar strategies may be useful for other ethnic and racial groups, and that's what we're trying to do, or we're working now, and can be applied to other organs, as I mentioned, for liver transplantation. Well, thank you very much. It has been a pleasure and honor to be with all of you, and I open if there's any questions or comments, I would love to hear.
Thank you, Dr. Caicedo, for a wonderful presentation. I want to applaud you and the team at Northwestern and in Illinois for the advocacy to the minority population and providing the support. We have multiple questions. If you don't mind keeping the last slide so people can get your email, if there is, because we're not going to be able to answer all the questions, so this way they can reach out to you directly. The one question that came up is, what kind of outreach have you done beyond just providing the service? Did you reach out to communities? Did you reach out to referring physicians? How do you bring that message out about this program?
Right. Then basically, this is a very important question. Then the first cultural difference in Hispanics is the person that manages the patient is the primary doctor. Then we're talking about kidney patients. Usually most of the programs will do the outreach with the nephrologist. But in this community, the primary doctor is the one that manages the patient, usually is the one that speaks Spanish, and they is the one that start referring the patients to whoever whoever is needed. Then in our approach, we combine both. We outreach, sorry. We combine, we outreach the nephrologist as well the primary doctor. Second, we have to go to where the patients are, and the patients are on dialysis. Then we're trying to go and do the education on during dialysis. And then we have a social worker that is Hispanic and bilingual. Then she goes to every dialysis unit. Out of all dialysis units that we have, we focus on the one that has higher concentration of Hispanics. And then she's going, and then she's going there, and she'll stay kind of 2 days to make sure that we capture the two dialysis cycles, the Monday, Wednesday, Friday, and Tuesday, Thursday, and Saturday, as well Monday in afternoon. Then she'll spend at least 2 days per dialysis, and she talked to patients. Because the problem in dialysis is, even though it's a mandate, then the nephrologist or the dialysis unit needs to educate about transplantation, usually it's not done. And patients don't learn too much about donation and transplantation dialysis. And then not only we educate the nephrologists and the chart nurses or social workers there, but also we spend time talking to patients directly. And third is the patient itself. I believe, I consider the Hispanics, the patient itself is the best marketing tool. it is not about money, it's about motivation. As soon as we transplant them, I give them a mission. And I said to them, now that you have received this gift of life, if you accept that your mission is go and help other 10, 15 Hispanics. And they cry, say, oh, thank God, I'm so grateful. And they go and they talk to other Hispanics because they have experienced the same fears and concerns. And we receive a lot of patients that has been, outreached by the patients itself, and they are grateful and they are willing to do it and they really like to do it. Then we have been, I have been involved in more than 1,500, internet, media, TV, radio, but those are not as important as just focusing on dialysis units and talking to their patients and the PCP and nephrologists.
Thank you, Dr. Caicedo. Maybe one final question we may have time for. And again, I urge people to have your email. And thank you for being generous with your time. The question is, do you need a surgeon who is natively Hispanic or Latinx to be part of the program or to be comprehensive for the program? And regarding the staff, would culturally educated staff or linguistically educated do the job? Do we have data on that, or do we need to have native speaking individuals?
Right. Then I think the first thing is I believe, and we are studying this now, but I believe that if we recognize patients' culture and we're trying to use those, if we can, even if I'm not Hispanic, but still speak Spanish and I'm competent in that culture, I think should be enough, right? As long as you recognize that your patient is different and your approach is different, the medicine probably is the same, but the approach is what needs to change. And of course, if you can have, and what is interesting in our grant, as we are working with other centers, our study site is in Mayo in Arizona and Baylor in Dallas. At the beginning, they were saying, but we don't have anybody. I said, are you sure? Do you have a good census of your team? And then I did the study visit, and then I said, can I talk to your team? So yes, go ahead. Then the first guy that I started talking was a nurse, blonde guy, tall, blue eyes guy. And I started talking to and he said, oh, I'm from Argentina. There you go. And they didn't know that they have an Argentina nurse right there. And if I'm in Chicago, a lot of people that work in the hospital by default are going to be Hispanics, but you can judge people by the color of their skin or the color of the eyes to assume they're Hispanic or no. Hispanic is not a race, it's a cultural background. Then we have a white Hispanics, African-American Hispanic, Asian Hispanics, and then we need to ask directly. And most of the centers, they don't have a good census of their own team. And most likely they will have people that can help. I have 49 is not because we hire 49 necessarily, it's because I identify the people, say, oh, you speak Spanish, I want you here, I want you here, I want you here, but they're already in the system, most of them.
Well, thank you, Dr. Caicedo. This makes a lot of sense. We are right around the hour. I want to be respectful of everybody's time. Again, I urge people to email Dr. Caicedo for additional questions. And again, I cannot thank you enough for making the time and applaud you for the remarkable initiative you and Northwestern and the team have done, both locally and nationally, to raise that awareness. Again, thank you so much, Dr. Caicedo. Have a wonderful day. I want to thank
you so much. It's been a pleasure, and thank you for inviting me.
Thank you. And thank you to all the attendees for attending, and have a wonderful day. Bye-bye.